Hello, everybody. This is Irma Jennings, and I'm here with Dr. Belinda Beck. And we're going to be talking about something that's so important to us, which is how do we exercise our bones through a proven method that will help us with longevity. But before we start, a couple of things that I wanted to share is Vicky will be taking questions in the chat. So please put your questions in the chat. I did ask earlier if people are on the call and they're physical therapists or doctors to please let us know that by identifying yourself in the chat, just so we know. You don't have to if you don't want to. And also, I think that's it. Keep your phones or your computers on mute so we don't have any background. That would be really helpful. Before we get started in the introduction, I just wanted to do a little fun fact, and that maybe some of you know this, but there is a silver tsunami going on in the United States, which means that 4.1 million Americans will turn 65 in 2024. 4.1 million Americans. Half of them are women, and typically this is when women go for their DEXA, unless they're part of the community, then they know to go earlier. But this is the first time they go for the DEXA, and this is when they all wake up and say, oh, how could that be? I eat right, I exercise, I do everything, but how do I have osteoporosis? So there is going to be a rush to people finding endocrinologists, which is very difficult. And it's just the reality of an aging society. And between now and 2030, there will be 30.4 million Americans turning 65. And on average, we can assume at least half of them are women. So let me tell you a little bit about myself. My name is Irma Jennings, and I am an osteoporosis patient navigator. My company is Food for Healthy Bones. That's how I started. I love eating. I love feeding my bones. I think about food all the time. I think about tweaking food to make it bone sensitive and bone dynamic. But my real passion is how do I help people once they've been diagnosed and in that, oh my goodness, place, not to panic and just take medicine right away, because there's a big conversation between here's your DEXA and here's your prescription pad. So, and part of that is to reduce the level of fear in everybody who is part of this community. And we all are in one way or another, whether or not it's a mother or a sister or ourselves, osteopenia, osteoporosis. But the whole idea about fear and how do we reduce fear? And part of it is we listen to Dr. Belinda Beck, and she is reducing fear by talking about something that might feel like, I don't know if I could do that, but she will show you and show us how we can. So, Belinda, would you like to introduce yourself? Because there's just so much about you and where you've come from and what you're doing. That would be great if you could do that.
Yeah, very happy to. And thanks for inviting me to speak, Irma. I was delighted to be here. I probably can't summarize 40 years of career in a couple of minutes, so I'll just hit the main points. So my original training was actually as a physical education teacher, and I hated that, I've got to say, but it did give me excellent background and an understanding of human anatomy and physiology and the importance of exercise. And that has carried me through my entire career. After that, I went on to do a Master's of Sports Medicine because I thought I wanted to be a physical therapist or an athletic trainer. Also decided that I didn't want to do that because I got hooked on research, and I began investigating bone, as many people do, because of my own bone problems. When I was a runner and a field hockey player, I constantly had sore shins, and not only could I not figure out what was causing it, but I couldn't find anybody who could tell me what was causing it and how to prevent it and treat it. So that started me on this pathway of looking at bone issues. I started with an animal project in my PhD at University of Oregon and working in Clint Rubin's lab in Long Island in New York.
Oh, I didn't know that you worked in his lab.
Well, I only went over there for 3 months because he was doing work. Was working with a fellow called Mark Otter who was looking at streaming potentials in bone. And so I don't go down that path too deeply. It was really a fantastic opportunity because, of course, that's a hotbed of mechanical loading for bone. And to have worked with and continue to work with Clint has been one of the highlights of my career. But I was based in Oregon, where I was, my teaching fellowship was paying my way. So I was teaching anatomy there at the time. And that's what got me through my PhD. But after I graduated from there, I decided that I didn't want to kill animals my entire career. And so I got out of animal research and started doing human research. And that's why I went to do a postdoc at Stanford, where I worked with Bob Marcus, who had done some work in exercise for people with low bone mass. He was an endocrinologist. Well, he still is, but he's retired. So I was there for about 3 years, and then eventually came back to Australia because I was offered a job teaching human anatomy at Griffith University on the Gold Coast. And that's where I've been ever since. And Griffith's been incredibly supportive. They've helped me develop this amazing lab with every toy that you could possibly want to measure bone and to do these randomized controlled trials, which I'm going to talk about in my talk.
Wow. Thank you. Thank you for doing that, for getting so educated. All right. So why don't you let us know all about where you are and what's going on with Onero and Liftmore? And
so, can you folks see my screen?
Yeah, we can.
Okay, so yeah, definitely better for me to show pictures because I've got a lot of things I want to describe. Picture is definitely worth 1,000 words. And just, of course, you're all pretty familiar with what osteoporosis is, but just to make sure that everybody's on the same page, because some people do get confused between osteoporosis and osteoarthritis. And so what we're talking about here is a condition of reduced bone mass. And you can see the one on the right is looking pretty moth-eaten, and also looks like the sides of the bones, the vertebral bone has collapsed a little bit, and you can see little micro fractures in here. So this is an example of an osteoporotic bone. So the bits of bone that you can see in the vertebrae on the left that are sticking out from the top, they're examples of osteoarthritis. So it's a condition of, involving the joint, not the bone. So that's the difference between them. And of course, if you have a fracture at the front of the bone in the spine, you can get this wedge-shaped, you can see down the bottom on the left here, a wedge-shaped vertebrae. And if you have enough of them, they come together to create this Dowager's hump, or kyphosis. The reason why I put this image of the late Pope John Paul is just to remind us that this is a condition that also affects men. Now, oftentimes we think of osteoporosis as a T-score of minus 2.5. That is really a diagnostic definition. Osteoporosis is actually a fracture definition. So it's we use DEXA to scan how much mass we have, and so doctors can determine when they should be prescribing meds. But in fact, if you have had a low trauma fracture or a fracture that has happened, that doing something that wouldn't ordinarily cause a fracture, like lifting a grandchild or carrying your groceries, then we do still call that osteoporosis, even if you don't have a T-score of minus 2.5. So moving on. So this is really the first slide to just demonstrate the effect of mechanical loading, the physical force of onto bone. And I show along the top the effect of withdrawal of that physical force. So on the left-hand side, you can you see my cursor with
Yes.
Mm-hmm. Okay, so I don't have to keep telling you where I'm pointing. The astronaut in microgravity has been unloaded because the force of gravity is no longer pulling on his skeleton. And so way back in 1969, they discovered that these astronauts were excreting huge amounts of calcium, and this is because they were unloading their skeleton. The skeleton, not to anthropomorphize, but does recognize when it's not being loaded, and it will get rid of excess mass. It's just the body is an extremely efficient machine. Same thing if you have a spinal cord injury and you stop loading your lower extremity, you'll lose bone in your lower extremity. And this image over here is some of my anatomy slides. You can see when we're babies and we're not chewing, we have very little what we call alveolar bone. And also these side bits, the rami of the mandible, don't stick up straight because we're not chewing and placing force through the jaw. As we grow, develop teeth, and we start chewing, that ramus becomes very straight and we get lots more bone under the jaw. And then if we happen to be unlucky enough to lose our teeth, and stop chewing, then we actually will lose that bone. And you can see the ramus starts to begin to angle backwards again. So Wolff in 1892 tried to describe this in a mathematical way. And so ultimately the law of bone response to mechanical loading was attributed to him, even though he never actually said it in those words. On the flip side, if you look at bone that is overloaded, we were just talking about gymnastics in the chat the other day, just before, you know that people who overload their bones chronically, such as Olympic gymnastics, do develop very, very strong bone mass. This is an example of an animal study where a beagle had one of his limbs put in a cast. And over the course of 20 months, you can see the effect of unloading on his bone. And this really looks like an osteoporotic femur in an old person who has stopped walking. So you can see that the cortex of the bone, that's the shell around the outside, has become very thin and moth-eaten, lots of little holes everywhere. Whereas the other limb that wasn't in a cast, that was taking all the extra load, you can see how thick and healthy that is. Few holes that you can see. And also, if you look closely, you can see there has been new bone that's been laid down on the inside and also a little bit around the outside. The effect of that is to massively increase the strength of that bone that's been overloaded. And this, of course, in reverse, is to massively weaken the bone. We can see this effect in tennis players who chronically overload one of their limbs. Now, what is a bit curious, though, is that for many years, lots of exercise studies had been done which had not been able to show that doing exercise interventions in adulthood was really having much an effect at growing bone. And so this is a meta-analysis. Many of you would be familiar with this, those who are not. It's when you put a whole lot of different studies that have studied the same sort of thing, and you put all of the data together, and you end up with this sort of averaging effect. And down the bottom, you can see in the circle, it shows that there was really no overall effect of exercise on bone. Potentially it prevented loss, but it wasn't causing bone to grow in adulthood. And this gave the doctors a very negative message. And they were thinking, well, if somebody comes in with osteoporosis, why would I give them exercise when I can give them a drug that we have evidence will actually add bone? Now, there is one dot point here that is actually an anomaly, and I don't have time to go through why, but this is actually a fake data point, and the people who did the meta-analysis actually misrepresented that. So that is not a thing. So I went through the process of pulling out the effects of these drugs that we're all probably quite familiar with, although maybe not these names. Denosumab is Prolia, alendronate is Fosamax, teriparatide is the old Forteo, romosozumab is Evenity, the new drug, and zalendronate is, in Australia, we call it Aclastar. So what you're looking at here is percent change in lumbar spine and femoral neck, so this is at the hip, BMD. And so you can see that all the drugs look to have lovely effects, particularly romosozumab. That's why it's the hottest thing at the moment, BMD. And by comparison, if you plot the results of that old meta-analysis, this is not looking very favorable. And you can understand why the doctors are thinking, well, why would I bother? So this is a cause for a bit of pondering for somebody like me who had done animal research and knew that if you overloaded bone, you could actually get a response. And you can see from this comparison of tennis player arms, you actually can get a response out of bone, even in adulthood. But the studies were not showing this. What on earth was going on? And this was a bit of a moment that I had probably at the end of the first decade of this century. I was really scratching my head and thinking, we can do better than this, surely. The reason, of course, is this conundrum that we have, where we are all, and doctors in particular, very concerned about doing harm. So we don't want to hurt somebody who looks like this is somebody who's obviously had multiple vertebral fractures. They have an advanced kyphosis. So that means that they're very frail and it wouldn't take that much to fracture them. So part of the problem is the fact that we were terrified of hurting anybody with exercise. And what did that mean? It meant that by giving somebody heavy exercise, we were going to be putting them at risk of fracture. And as a result, these are the kinds of exercises that we were testing in our exercise studies. So seated resistance bands, these are probably about half a kilo dumbbells. Seated again, just doing bicep curls. Mind you, this is not the area where most of the fractures occur. Cycling, low impact. Walking, very low impact. Swimming, non-weight bearing, and Tai Chi. These are all the exercises that were shown to not increase bone mass and in some cases not even prevent loss. But what we do know from these animal studies is that size does matter. If you want to get a response out of bone, you have to overload it. And from this very early study, Rubin and Lanyon from 1985 is when they reported, I believe it was Clint's PhD study, is when you look, they have a turkey ulnar preparation that they use where they are able to unload the shaft of the bone and then they can artificially overload it. So in the case of a turkey ulnar that had been completely unloaded, you would see a loss of bone. If you load it about the same amount that the turkey loads it during the course of its own day, stretching its wings and flapping them about a bit and ruffling its feathers, you sort of maintain bone. To get an improvement in bone mass, to grow bone, you have to overload it. And this has been known for decades. So let's call her Esme, is taken to the gym and she's told to sit down and pick up these half-kilo weights and do bicep curls for her exercise for her osteoporosis. And then Esme goes home and on the way she stops at the shops and this is what she's carrying home. So I think we can quite safely say that this is not overloading Esme. This is what Esme is already carrying during the day. So we are not doing Esme any favors by wrapping her in cotton wool, sitting her down and lifting these weights. All we're doing is charging her for an ineffective exercise intervention when she could be doing something else with her money. So this is the reason why we did the Liftmore trial, and I've got that big old cannon there to as a metaphor for pulling out the big guns. It got to a point where I just felt like we were not overloading people with osteoporosis because we were scared of hurting them, but in actual fact, we didn't know whether we would hurt them or not. And the only way to test that is to do it scientifically in a randomized controlled trial. So that's what the Liftmore study was. So Liftmore is actually an acronym. It's not that I can't spell. The acronym is probably not important. We really just like that word. So it involved a high-intensity resistance and impact training intervention versus a very low-intensity home program, very similar to what many people were giving people with osteoporosis. That is, a bit of walking, bit of stretching, a few bodyweight lunges across the course of 8 months. We recruited people who had low to very low bone mass. So their lumbar spine T-score and their femoral neck T-score coincidentally ended up almost identical, not quite osteoporotic as the mean with minus 2.1, but actually almost half of the sample were minus 2.5 T-score, and there were people who had existing fractures. So not the oldest old. These are people who probably 10 years post-menopause, pretty average height and weight, and we recruited them and randomly allocated them to these groups. The important thing was we introduced this heavy lifting program that we knew could be dangerous with a great deal of care, attention to very strict technique, supervision, and gradual increments. And what did we find? Well, we were extremely excited to see suddenly we get an increase in bone. So we answered the question that, can you increase bone mass in people who have low to very low bone mass? And the answer was yes, if you load them enough. So looking at the lumbar spine here, you can see our control group with that low intensity home program lost bone. The intervention group gained about 3% of the spine for a net gain of about 4%. Interestingly, though, a vast majority of the sample actually had some form of improvement, whereas this was the average. We had some people gaining almost 12% bone at the spine. Now, at the femoral neck, we had the same sort of response. Most people did gain a bit, but on average, that gain was quite small. And this was a real head scratcher for me. It was still significantly different between groups because our control group lost a considerable amount. But this was really disappointing to me because I thought, well, this is just like all the other exercise programs. We're not really able to add much bone at the femoral neck. Luckily, because I have this fabulous lab full of excellent equipment, I have a piece of software called the 3D Hip Shaper, and this allows me to look at the three-dimensional shape or the geometry of the proximal femur, which is what most people refer to as the hip. Actually, the hip is the joint, but this is the femoral neck, so it's where your thigh bone articulates with your pelvis. The femoral neck is where most of the hip fractures occur, but they can occur in other areas here. What was so astonishing was that although when we looked at volumetric BMD with this 3D shaper, the results were just like the aerial BMD, because remember, bone mineral density that's measured from a regular DEXA scan is two-dimensional. There's an X-ray source underneath the machine and a detector at the top. And so this X-rays go through you and you get a projected two-dimensional image. And that, of course, doesn't tell you anything about bone shape, really. That's what this 3D Shaper software is supposed to do. So if you look at the femoral neck total cortical thickness, you could see that there's this net benefit of 13.6%. So the difference between the control and the intervention group, thickening of the femoral cortex. So if you remember where I showed you that image of the dog bone, the one that was put in a cast, that was what I'm talking about. When I'm talking about cortical bone, it's the shell around the outside of bone. Remembering that the inside of the femoral neck also has trabecular bone, which is that very networked bone that you saw on that vertebrae that I showed you right at the start. So it has two kinds of bone, but it's the outer shell that was thickening. And if we looked at the lateral cortical thickness, so that's the thickness of the cortex on the top side of the femoral neck, there was actually a 27% difference in our intervention group and our control group. So what this is actually showing is that while the BMD might not be growing enormously in people in response to this exercise program, we're actually putting new bone down in exactly the site that we want it. That is where fractures tend to propagate. So this was very exciting and certainly made up for my initial disappointment that we hadn't really improved the BMD at the femoral neck very much.
Can I pause for a second? A lot of people are not aware of the 3D Shaper. 3D Shaper is a independent device that attaches to the DEXA, as I understand it, Belinda. It's created out of, it comes from Spain, Barcelona. And I had interviewed a couple of the gentlemen, and it's on my YouTube. And the reason why I did that is because Belinda was fortunate enough to have it in her clinic. It's not readily available to most common people. I think Columbia and New York has one, but waiting for it to come out. But Belinda's point is why it's so exciting is that not only did it confirm her work and her study, but this actually 3D Shaper allows the doctor to see if in fact you have weak hips and you're taking a medication for your hips, whether or not that particular medication is working on your hips. So we have yet to see that in full blown, and hopefully it will come out soon. So I'm very excited that it's here, that you used it. I just also want to go back to the Liftmore that you were referring to on the left side. How long was that study going on, or the trial?
This was 8 months. Typically, we would like to do a 12-month intervention for an exercise study because, as you would all be aware, it takes a long time for bone to adapt, and DEXA is not very sensitive to anything that doesn't have mineral in it. So even though you might start to grow new bone immediately, you start stimulating it, it has to be mineralized for DEXA to be able to detect it. So yeah, 8 months was what we ended up with because this was a PhD program and I have to graduate my students, so I can't keep them there for too long. Mm-hmm. So 8 months was the absolute minimum. I thought that we would be able to detect a change, and it turns out that that we were correct. So I suppose the next thing to mention is the fact that hip fractures are they're the nemesis really of osteoporosis. Many people go through life with low bone mass and they never have a fracture because they don't have a low trauma event. I would say a fall can actually be considered a high trauma if you fall directly onto your hip. And we know that over 90% of hip fractures occur as a direct result of a fall. So we really do need to prevent falls. And in fact, before Liftmore came along, that was the sole focus of our intervention for older people with osteoporosis, was to prevent falls for this reason. So we wanted to know whether Liftmore would help prevent falls. Now, it's really hard to track falls in relatively small cohorts. So this was about 100 people randomized to either trial, so about 50 in each group, and not really a large enough study to track falls over the long term. So instead, we looked at falls risk factors. So what you're looking at here in the bottom, LES stands for leg extensor strength. Leg extensor strength is absolutely vital to preventing falls. If your lower extremity is weak, then you're much more likely to fall over. Back extensor strength is BES. So these are your back muscles that help us to stand up straight. Timed up and go is TUG. That's getting up out of a chair and walking 3 meters and walking back and sitting down. That's an indication of mobility and frailty. FTS is 5 times sit to stand. That's what this person is doing, standing up and sitting down 5 times in their time. So that is, it's sort of an indicator. It's leg function, but also power. And then functional reach is the next one. This is standing still and reaching forward as far as you can without falling over. So this is a sort of a balance test, a very standard balance test. And the last one is vertical jump. This is definitely an index of leg muscle power, how high you can jump. So at the end of the Liftmore study, you could see that we definitely had significant difference between our groups, certainly in leg extensor strength and back extensor strength, but also in all these other risk factors for falling. So this was a real win, we thought, that people's function and strength had really improved. The most impressive ones, of course, were leg and back extensor strength. But even small gains in these other functional outcomes really can make a big difference in terms of your risk of falling. Now, I can hear you all saying, yes, that's all very well and good, Belinda, but was it safe? This is what we've all been worried about with heavy lifting. And so, of course, we were tracking at what we call adverse events in clinical trials, and also some of these other markers of vertebral fracture, because it was the vertebrae that we were concerned about fracturing. In actual fact, if somebody had a fracture, you would expect them to be shrinking. Our intervention group actually grew. Now, obviously, a 65-year-old woman is not going to be growing. So this is postural. So the change in posture actually had them standing taller by the end of the study. Whereas the control group, as you all know, if we're not doing anything very much, we do tend to shrink over time, and that's what happened in the control group. At one stage in the study, this wasn't right at the end, we did a little bit of a sneak peek halfway through the study. There was a centimetre difference between, I think that shrank down to about half a centimetre by the end of the study. There was a 5% reduction in kyphosis. So the person you're looking at here was at the beginning of the study. She obviously had prevalent fractures. She had this kyphosis that we measured at 47 degrees. By the end of it, that kyphosis had reduced to 34 degrees. Now we're not miracle workers here. We're not rebuilding a wedge fracture. That once it's fractured, unless you have surgery, it will be like that. So this change is a postural change, a mobility change. So her mobility to be able to extend her back. So you can see that here she's in what she was calling full extension. This was extending her back as much as she could while she's bending over and holding onto a bar. You can see that she can only look at the floor. In this case, same position, but she can look ahead. And that makes all the difference when you're walking, if whether you can look up and look around you and be aware of things coming towards you that might increase your risk of falling. We also actually did lateral scans on the DEXA. We've got really nice resolution DEXAs these days, so we can do that. We measured the front, the middle, and the back of these vertebral bodies, and there were before and after the intervention, and there was no evidence of vertebral collapse. No one had a vertebral fracture. There was one mild soft tissue adverse event, which is another way of saying a muscle strain during one of the exercises once, and that was in 2,600 sessions. So I think we can say that it was pretty safe. This woman went and had physio for 2 sessions, came back and kept lifting.
So while you have the slide up, tell people again that fractures in the lumbar region happen where and why?
So in the lumbar region in particular, not thoracic region?
Well, whatever, all of it.
Anywhere? Yeah. Mm-hmm. So this is, so the spine, everybody thinks of the spine as being straight, but it's not. It has this lovely S shape, and the arrangement of the bones puts us in that position. This is advantageous physiologically for a number of reasons I won't go into. But the problem with the curvature of the thoracic spine, this is the thoracic spine is the part of the spine that has the ribs attached to it. You can see the ribs here. The problem with this having this curvature, it's an anterior concavity. That's how we would describe it. Is that if you do lean forward to pick something up, you're actually exacerbating that curvature. And if you have a very weak vertebral body, then that extra force that occurs towards the front of the vertebral body can cause a crush fracture. So that's why, although it looks like she's bending over here, this is just the deformity that has been caused by previous fractures. We would never ask somebody to do a deep forward flexion, particularly with load. So she is not bending down to pick something up in forward flexion. Her, what we call the extensor moment, the force that's being applied to her back here is an extension one. All of these extension muscles are working down the back here to more or less open up the front part of the spine here. So we would never ask somebody to bend over and touch their toes, for example, or do anything in that really bent over position and lift. I hope that answers your question, Irma.
But in particular, don't people fracture in the front of the whether or not it's thoracic or the lumbar? It's the front of the spine versus the back.
That's what I'm saying. That okay. Those, and it's normally due to that functional sort of squashing of the front of the bone. Those wedge fractures do tend to happen. And when I showed you the little old lady at the very start of the image who had the very severe kyphosis, and there was an image beside her of an MRI, if you look closely at that image, you'd see these wedge-shaped fractures where the fracture occurred at the front. But we mustn't forget that it is possible for a fracture to completely crush and just collapse. So all osteoporotic fractures are not in the anterior part of the body. They can just be complete crush fractures where the front and the back collapse the same amount. It's my belief that probably part of the reason why we more likely to fracture at the front than the back is because we have all these other vertebral structures that help to support the back as well.
Thank you. So
I'm not going to go through all the detail here, but I just wanted to put this image in to to highlight the fact that this deterioration in posture that's caused by those anterior vertebral fractures does increase our risk of falling. And you can see how hyperextended this woman has had to place her neck in to be able to look forward. And even still, she can't really still look directly ahead, just to dance at probably her son's wedding or a grandson's wedding. So this position is a position from which we are much more likely to fall than if we were standing up straight. So never underestimate the importance of posture. And that's why we think that the effect of Liftmore, the Liftmore protocol was so important, not just for the bone outcomes, but for function and posture. So there are many, many more outcomes that have come from our studies. This was the first publication from Steve. Steve Watson was my PhD student. Always the idiot supervisor. I can never resist the urge to put rabbit ears behind my students' heads when we have photos. And he published in JBMR, which is Journal of Bone Mineral Research, which is the most prestigious bone journal. After that, he also published the safety findings. This is the measurement of the lateral scans that I just described. And then Amy, there's the rabbit ears again. Amy Harding was my student who did Liftmore for Men. That's the Liftmore M study. And she did the same study, only we compared the HIRIT program with the OsteoStrong program and found that it was definitely superior. So once again, we got that published in JBMR. She then went on to, this is an image of OsteoStrong used to call this device biodensity. So that's what it was called at the time. But they were all of them, the exercises were in one machine. These days, I think they've divided it into 4 and they call it OsteoStrong now. This is an example. This was a parallel group to our HIRIT group. And it was worrisome because we found that there were 5 fractures in the OsteoStrong group and it didn't increase bone mass. So we sort of answered 2 questions there. Does the HIRIT program improve bone in men? Yes. And does OsteoStrong work? No. And are they safe? HIRIT, yes. OsteoStrong, no. She also published some information about the bone geometry. So then along came Melanie Kissel-Fischbacher, another research PhD student, and she tested the what we were then calling Oneiro, because we'd opened the bone clinic by that stage, program against another exercise program called Buff Bones. This is a Pilates-based program, and I was reasonably certain that this was not going to improve bone mass. Look, they're lying down, so it's not weight bearing, very low intensity. So we cheekily used that as our control group, and sure enough, it did not improve bone mass, whereas the Oneiro program did. The main reason for doing this, the MedXOP study, was to actually see if we could compare the effects of medication with the Oneiro program, and then the combination. And I can talk about that more later if you like. She also published the bone geometry outcomes as well. So Melanie also did a meta-analysis, and this was to revisit the combination of exercise trials that had been done over the years and try and parse out the effect of intensity so that we could get our heads around the fact that back in the day and as early as 2015, the meta-analyses results showing that there was no effect of exercise on bone in people with osteoporosis. We wanted to show that this was reliant on intensity. Melanie did a really comprehensive meta-analysis. She included 53 studies, so by far the biggest meta-analysis that had ever been done. And she categorized everything as either low, moderate, or high intensity. And you can clearly see here that it's really just the high intensity exercise programs that are improving lumbar spine BMD. So revisiting this, my circle's gone a bit wonky, but revisiting this exercise versus drugs question, And this is the slide that I showed you before with the drugs and the effect on BMD for percent change in lumbar spine and femoral neck BMD compared to exercise. The thing is, if you look at the effect of those elements on fracture risk or incidence of fracture, all of a sudden, exercise compares even better than the drugs. And this is because exercise is not only affecting BMD, but as we've seen, it's putting the bone where it's needed, and it's also preventing falls. So falls are not influenced by drugs.
Mhm.
So it's really important to emphasize the fact that exercise actually does have a very important role to play in fracture prevention. It's important not to just look at the BMD effect, because I suspect many of those studies that showed that they didn't actually increase BMD, I bet you if you continued doing many of those exercises over time, that the falls risk would be lower, and so fracture risk would be lower, even if they weren't high intensity exercise. Not all of them, but certainly some of them. Now, recently, another fellow did another meta-analysis that I thought was very interesting, where this is just in 2021, also published in JBMR, so it was a high-quality meta-analysis, showing that if you looked at exercise interventions that were not supervised, there did not appear to be any effect on prevention of fracture. But if you looked at the ones that were predominantly supervised, and this is not even including ours, you can see that there is this effect of fracture prevention. So whether or not supervision in and of itself is causing this effect, or whether that is really a marker of intensity, I suspect it's probably the latter. But they concluded that supervision plays a significant role in the reduction of overall and major fractures, with about twice as favorable in the supervised versus non-supervised. And that's a really important finding, and it's one of the reasons why I emphasize that supervision is really vital. And just as an aside, also, I think the recent World Falls Guidelines also noted that supervised exercise is more effective than unsupervised for preventing falls. So there you've got the double whammy of supervision being important for both bone and for
Well, and I want to say this about that oftentimes when we think that, no, I'm holding myself correctly, my back is straight, it's often not. So to have somebody there who's supervising, making sure that you're loading right is so key.
Yeah, that's exactly right. So how do we do this in the real world? Well, this is the whole reason for the bone clinic. And this is, although I am, I'm still a professor at Griffith University, that's my full-time job. I decided that because the program is quite risky, it's heavy, it's a risky population, the only way to really test whether this is a program that could feasibly be rolled out into the real world would be to do it myself. So that's in 2015, I opened the Bone Clinic, where we implement the exercise program that we tested in the Liftmore and Liftmore Men for Men and the MedXOP study into the real world. It is a business. I keep my prices very low because I want as many people to come as possible. I'm just really trying to keep my doors open, but I employ, this is my senior exercise physiologist who's been with me for the last 9 years. There's probably not too many people in the world who know as much about effective exercise for bone in safe environment than Katie. And this was my very first dietitian, because we decided to add in a dietary consult as well and make this a very comprehensive facility for people with osteoporosis, because prior to that, there was nowhere for these folks to go except to the doctor. So how we run the program is that everybody has a baseline assessment. Everybody has to agree to be a research participant if they come to the bone clinic, and they have a diet assessment as well as a functional assessment, and their bone density scans. And then they come for twice a week training, which is exactly what the high rep program was in Liftmore. And also I give educational seminars a little bit like this throughout the year where we talk about different things. We called the program Oneiro. It is the program that was done in the Liftmore study, but we've added in balance and mobility exercises. And we chose the word Oneiro because it's the Latin word for overload. And then at 12 months, people come back in for a follow-up assessment. So even though we've been open for 9 years, COVID absolutely knocked the wind out of us and it messed with my data in a very big way. So at the moment, I'm still just reporting our 4-year sample of people who had had a minimum 12-month exposure to Oneiro. And of that, there's about 415 people, of which 6% were men. You can see that the age, height, and weight very similar to what we found in the Liftmore study, although there is quite a deal of variety here. We also have probably the youngest person who has come to the clinic was about 23, and the oldest probably about 92. Similarly, the average T-scores are probably in the osteopenic range, about -2 at spine and hip, but we do have some very severe osteoporotic people, lowest being a -6 T-score. In this sample, the compliance, that is, people had come and attended classes, an average of about 60%, but again, there was a lot of variation in that. 107 were on medication at baseline. We do encourage them to stay on their meds. They're very disobedient. They often come to the clinic because they want to get off their meds. Only 29 were still on meds at follow-up, which is a bit of a worry, but you know, it's people's free will. They're allowed to do what they want to do. This is not a clinical trial. So what did we find? I guess I'm surprised to see that actually the findings look so similar to what we found in the Liftmore study. So it is just as effective in the real world with people with all manner of comorbidities when they come to us, that is, other things that are wrong with them, as it was in the more tightly screened Liftmore study, where we screened out people with severe knee osteoarthritis and those sorts of things. And apologies, my minus signs have moved, but you can see where they're supposed to be. This is a plot where I've put everything on the one side of the plot, even the negative values, because it's percent improvement. If I put the negative values below the 0 line, it just makes the plot very hard to see. So what you see, if there's a negative score, it is a positive thing. So this is kyphosis, so the postural, the dowager's hump. It reduced 7.1%, which means that this was an improvement. The same with this one, this was tandem walk. So walking heel to toe along a 6-meter line. The time reduced, which means they got faster. So that's an improvement. Timed up and go, 5 times sit to stand. Also, their times got faster. This is percent fat. Surprisingly, went down, although not really surprising because their lean mass went up. So this is a percent. So possibly you would expect their percent fat to go down because they got more muscle. And that, I know I'm going at this very higgledy-piggledy, but over here you can see that weight actually increased 1%. And that, I always remind people, this is a good thing because their lean mass improved and their fat mass, their fat percent went down. So this is all good weight. You can see that height, there's a 0.001% change, which is essentially no change. And this is a good thing because remember our control group in Liftmore actually lost height. So people are maintaining their height. But all these other BMD findings here, lumbar spine, femoral neck, and whole body, all going in the right direction. All of the functional outcomes going in the right direction. Now, remember that many of these people came off drugs and the vast majority of them would have been on Prolia. You're probably aware of the loss of bone that occurs when you come off Prolia. So these findings are in spite of the fact that many of them would have had that potential to be losing bone like crazy for 6 months after they came off Prolia. And we appear to have been able to rescue most of those. So if you look at that whole sample, this is 415 people all plotted in one, what we call a waterfall plot, because it's from the highest amount of change to the lowest. And you can see that we've got about, I can't see that because it's behind the Zoom thing, but I think it's about 82% improved in lumbar spine BMD, and at the spine, almost 80% improved in femoral neck BMD. I do also have a sample of data from the 3D hip, but 3D hip takes a long time to analyze. And so it's not something that we can do for everybody in every clinical appointment. And speaking to your point before, Irma, this is probably why many of the clinics won't adopt 3D hip, because it does take quite a deal of time to process those data.
But it's so effective.
Yeah, it's great. Is it safe in the real world? So are we hurting people at the clinic? So this is somebody who had 7 fractures before she started lifting, and we not only didn't hurt her, but her posture is so much better. This is almost 45,000 training sessions in this group. We've had a total of about 28 injuries, a 51% reduction in falls, and a 78% reduction in fractures. Now, again, if you think back of those plots I showed you from the meta-analyses data, it looked like exercise was reducing fractures 51%. So we are beating that right now. The problem is, and it's not really a problem, is that our numbers of fractures are so low that it's difficult to have enough data to be 100% convinced by these. So ever the scientist, I'm not resting on my laurels. These are numbers that we will have to reproduce over time. This is an email from one of our clients. I love it because these are completely unbidden emails that we receive. This is an example of somebody sent one in August of last year. I wanted to share with you what happened at my annual visit to the doctor this morning. The results of my bone density test and blood tests had returned, and Dr. D said all the results were good. Bisphosphonates had worked well. I didn't interrupt her when she went through and explained all the positive results, no losses, some improvement. It was at the end when I said I'd chosen not to use the drugs. So I guess the point is it has taken a while for doctors to get on board, but around Brisbane, we now have a very large cohort of doctors who are referring to us. It's not that they're not prescribing medication. Of course, there is a place for that, but they are beginning to believe now that there's not just one kind of exercise for bone. So just to summarize all of that up into a picture, here's our fractures. These are the things that create risk for fractures: low BMD and poor bone geometry, which influence bone strength, and falls. We know that all of these things influence the risk of falling. Muscle weakness, poor balance, and so on. All of these things are amenable to, if we change them, if we improve them or reduce them, we can reduce falls risk, and we can improve bone strength and ultimately reduce fractures. Now, bone drugs work on these 2 things. Exercise works on those 2 things and all these other things. Now, again, I don't want you guys to get the idea that I am anti-drugs. I'm not. I am pro-exercise, and I have to be the advocate for exercise because it does not get advocated for enough. So I'm just trying to bring to everybody's attention that exercise has this very important, very powerful effect on bone strength and falls risk, which can reduce fractures, and this should not be overlooked. We also need to remember that there's a point where people are not eligible for bone drugs, and that is when they're osteopenic. But there's no reason why you can't give somebody exercise when somebody is osteopenic to prevent that first fracture. And remembering that most people who fracture are osteopenic just by virtue of the fact that there are more people in that group.
Right.
So it's really important to remember that exercise is preventative. We want to stop the first fracture.
And oftentimes the patient is met with their doctor saying, oh, you're just osteopenic. We'll watch that. And your point is, no, we'll exercise our way out of that, perhaps.
Yeah. exactly. We've got plenty of cases where we've been able to do that. Now, I'm showing this one at the risk of anyone taking home the message that I think this is good. I am, with all due respect for whoever developed this for the International Osteoporosis Foundation, I am wanting people to know that not all information you see online is good information, helpful, or true. And I'm not talking out of school. I said this at the IOF meeting in London in April. These exercises that the IOF have said are to improve bone for people with osteoporosis are not effective. And it is worrisome to me that they are suggesting that they are. We know why they do this. I fully understand it. Back in the day, I would have said, yes, sure, this is good, because we thought we would hurt people if we did actual, decent, effective exercise. Now we know that we won't. It's time to stop spinning this message and giving people false hope that these exercises are going to improve their bone mass. Sure, they may help prevent falls, but I don't think they're even very effective for that. So beware medical sophistry. Reasoning that seems plausible is not sound. There is no evidence that those exercises will improve bone. Osteoporosis requires targeted therapy. You don't give people aspirin for bone health. You give them bone drugs. So you don't give people this non-weight bearing, low intensity exercise. You give them actual targeted exercise. So I probably don't have time. I don't have, let me see, I'm always talking too much. I don't have time to show you this patient testimonial, but I'll just, trust me, this was one of our patients just saying, thank you, it's changed my life. I put this up not as a blatant ad for Oneiro, but just because people always ask me, so where can I do Oneiro? In Australia, we obviously have the predominance of Oneiro providers just because I'm more visible here, but I have started selling licenses overseas. The problem is that you guys in the US have been slow to pick it up, and so there are not that many providers there yet. But I need you guys to be advocates. If you want somebody near you to do Oneiro, go to them and say, there's this program and you can offer it as classes. You can charge a fee. This is be part of your business. But this is what I need to do for my bones. And this is how most of these licensees have happened. You can actually click on those little red dots and the drop down will come down with their information. So if you're lucky enough to live near them, you might already be able to go to an Oneiro provider. The way to find that is just type in Oneiro locations and this map will pop up and you can find it yourself. In the meantime, there is Oneiro online. Now, I wanted to mention this again, not as an ad for Oneiro online, but just to tell people the difference. I am not a saleswoman or any kind of marketing genius, and I made a great big boo-boo by calling Oneiro online anything that like Oneiro, because they are not the same. Oneiro is a supervised, evidence-based, face-to-face program that will improve your bone mass if you do it consistently and the right way. Oneiro Online is predominantly a falls prevention program that is safe to do unsupervised at home. So it's not heavy lifting, and we have no evidence that it will improve your bone mass. But what we've done is included as much in there that will help to prevent you from falling. And there's some impact loading in there that is safe to do if you follow the instructions, that should help your bones a little bit. But it's not the same thing. It's very, very inexpensive, $5 a week or something, Australian dollars, which is about 2 cents American dollars at the moment. And there's also some recipes there for calcium-rich recipes. So they're not the same thing, but easy to do. There's no sign up or exit fee. If you want to do it, you just sign up and you can cancel at any time. So that's pretty much all I had to say. I know that you guys have some questions, and in particular questions about,
Yes.
osteoporosis.
Thank you. That was a very, very comprehensive presentation. Very much appreciate all the work and the dedication that you put into this whole massive program.